Joel Topf from Nephrology Times here. I'm here with Kathleen Liu. Kathleen, you've got a talk on Saturday. You're the Massry named lecture.
Yep.
And what are you talking about?
I'm talking about sepsis-associated AKI. Sort of my career has been about critical care and AKI, and so it sort of is a natural place to talk.
I mean, I think about sepsis AKI and it feels like a research black hole. It feels like a ton of negative trials. I feel like what I'm doing for sepsis AKI is almost exactly what I've been doing when I got out of fellowship, and that was a long time ago.
Right. Well, that's probably true and not true, right? I mean, a lot of things have happened in sepsis over the last 20 years, right?
Yep.
Right, we have early antibiotics, volume resuscitation, right? Things that
maybe less volume resuscitation
maybe
than we
less,
used to.
right? Maybe less, but kind of conceptually, this concept that like these basic care interventions, when delivered in a protocolized or standardized way, is really important, right? And I do think there's a future to sepsis-associated AKI, right? So, wearing my ICU hat, right? I do a lot of work. I've done a lot of work in the ARDS field, right? And I think the ARDS field, which is probably not something you think about all the time, is in a much better place than we are, and in a place where it really sort of sets a paradigm for AKI, right? So in ARDS, right, we've done a number of large randomized clinical trials, all negative. You could also argue a therapeutic black hole in some senses, right? But Carolyn Calfee, one of my colleagues at UCSF, now about 10 years ago, now a number of years ago, used some of these more novel statistical methods, in this case latent class analysis, and was able to identify two subphenotypes of ARDS that exist. And now she's been able to show over a number of clinical trials that you can consistently identify two subphenotypes. In many of those treatment trials, right, one of the subphenotypes is responsive to therapy, the other is not, right? Now, right, for, sort of taking a step back, right, they've now got to be able to show that you can do that in a clinical trial prospectively, right, and that those phenotypes hold up. But that at least sets a model, right? And Pavan Bhattacharjee now at the University of Washington has done a little bit of work in this in the AKI space, right? AKI is probably...
And it seems like AKI is dying for that. We have so many different etiologies, and to think that they would all be treated the same way or respond the same way, it's naive, right?
I think it is, right? I think now the challenge, right, with something like this, right, is you may really need to look for subphenotypes of sepsis-associated AKI separate from subphenotypes of cardiac surgery-associated AKI, right? But because those may be two totally different diseases, right? But I think there's a lot of, I think these novel statistical methods give us the potential to uncover new ways to look at a disease that is very heterogeneous.
So the fuel for these novel statistical methods is just large data models. Data sources, do we have that? Is that something that's available to feed these?
We do and we don't, right? I think that's the challenge, right? You need big data. There's a lot that goes on under the hood of those big data models, right? If you give anybody enough data, you can find patterns in the data, right? I think this is sort of best done in the context of, do you have some marker of disease responsiveness that you could add, right? Or do you have some biomarkers you can use in your model? And then do you create a model where you identify subphenotypes that make sense, right? I mean, I'll say, right, the ARDS subphenotypes are sort of things that make sense, right? Like one is a hyperinflammatory subphenotype, one is a hypoinflammatory subphenotype, right? And so you can see that in those, like, it's not IL-6 in and of itself that defines a subphenotype, but you can look at the patients and sort of say, okay, holistically, it makes sense that these are somewhat different groups of people, right? One has sort of an overall higher pattern of these biomarkers, and one overall has a lower pattern of these biomarkers, and no one marker defines the subphenotype, but they kind of make sense teleologically, right? I think AKI subphenotypes, to be successful, need to do the same thing, right? And there are some real challenges to subphenotyping, right? There's some papers, for example, from the Assess AKI cohort, where depending on the inputs that you put into the subphenotyping, you can come up with different numbers of subphenotypes, right? And so really, for this kind of work, you have to think about what is the purpose of my subphenotype and what am I trying to identify?
Well, and I think what you were talking about with the ARDS is that using the phenotypes as people that are treatment responsive, immediately you see why that's useful, right? Being able to say, hey, this is a place where we can at least retest this therapy and see if it works.
Exactly, right? But you have to kind of start with, I think you have to sort of start with the subphenotypes, right? And then see if you can, right? And one of the challenges for AKI is we don't have a suite of large negative clinical trials, right? Which is one of the things that makes a subphenotyping
more and more every year.
Yes, true. Very true, right? More and more data that we could use, right? But you really do need these large trials to sort of, ideally you have some large trials to start as a framework, because once you identify the subphenotypes, then you can ask, is there a differential response to therapy?
Okay, and I would say, when I say that AKI is kind of a black hole, the fact that our international clinical practice guidelines are over a decade old without being updated kind of speaks to that.
Yeah. Well,
right?
I think, no, there's more coming on that front, right? KDIGO is in the process of updating the AKI guidelines. I hope.
And when you say that they're closer to the publishing stage or the starting stage?
We hope that the guidelines will come in 2026, right?
Looking for the 2026.
Right.
Okay.
The work group has been constituted, right? The evidence-based review process is actively in process, right? I think I can say, as a member of the work group, I don't think I can say much more than we are actively working on the guidelines. I am going to work
as hard as I can to push you over the edge so that you get in trouble for saying too much.
But it's a work in progress, right? I mean, I think, right, the work has grown tremendously over the last, 13 years since 2012 when the last guidelines are published, right? But they're really due for an update, right? There was so much focus then on contrast nephropathy, right? And we've had a number of trials published since then. And right, as we think about AKI now, contrast nephropathy is a tiny portion of what we need to think about when we think about prevention and treatment.
Can we say that again? Contrast nephropathy is a tiny, vanishingly small.
Yeah. But people still care about it.
Well, they care about it in excess of its importance.
Yeah.
I will get off my high horse on that one.
Yeah. That's every nephrologist's high horse, right? The high horse of renalism and the need to actually treat patients and not avoid risk when somebody has a low GFR for whatever reason.
That's right, and a good indication for whichever study that we're doing. Excellent, very good. Okay, so we're looking at 2026. We're going to get new AKI guidelines.
Yep.
And I'm super excited about that because I'll tell you that we also went a long time with without CKD guidelines, and those were outstanding. They knocked them out of the park with the update. I love that. So
I'm hoping we get.
You got to rise to that level. Absolutely, great.
No, the CKD guidelines have been a great addition.
Okay, and you're also working with the American Society of Nephrology on a new project.
Yeah, I'm working on the Kidney Health Guidance Project. Right, so this is a project really focused by the ASN not on creating guidelines, but on creating practical guidance, with the audience being American nephrologists or American nephrology providers in general.
American nephrology providers. And what's the difference between guidelines and guidance? That's fuzzy to me.
Right, so guidelines, right, really require comprehensive evidence-based review of the literature, right? And if you think about the KDIGO guidelines, right, they're really intended, let's take the CKD guidelines, for practice across all of the world, right?
Absolutely, that's right.
So the two guidance documents that the ASN has created so far, right, one focused on obesity, one focused on dialysis requiring AKI, are really focused on sort of what should an American nephrologist taking care of people with dialysis requiring AKI in the outpatient setting think about, right? Like, what are the practicalities of large dialysis organizations and how we, our lack of a single healthcare payer system that make care of these patients more complicated, right?
For Americans.
And the goal is really, the guidance that's sort of actively being worked on now is focused on, dietary additives, potassium, phosphorus, things like that, right? Again, with kind of this the concept of what does an American nephrologist need to know sitting with their CKD stage 3, 4, 5 patients, to sort of better care for that patient and make better recommendations.
And is the product just a document, or is the product what is
so
it?
The products so far have been publications in the JASON series of journals, right? So CJASON articles, right? Again, I think each of these, it's a work in progress, right? Because the guidance you need for different topics is a little bit different, right? So the AKID document is very much sort of a 3,500 word article with some practical recommendations, a proposed dialogue or care plan for transitions of care, right? The dietary guidelines are sort of at an earlier stage, but one of the working groups in that guidance, and I'll say that Sarah Samsel is really the ASN lead for this. She has a lot of experience creating guidance documents for a number of other societies and has really brought tremendous expertise to the process, right? For example, the dietary additives group has a specific work group focused on implementation, right? Because that's a very specific issue, right? That, and they need to help us think about how do we help patients of different ethnic backgrounds with different dietary preferences accommodate the same sort of nutritional recommendations.
And so that's one, it's in process?
That what is in process. I think the timeline is for the fall to winter of 2025, right? So these are guidance documents these are also produced on a fairly short timeline in the 6 to 9 month time frame.
Not the 13-year guide.
Not the concept being that we want things that are sort of timely, practical, right? That will help you in your practice tomorrow in Chicago, right?
Detroit.
Right. I got myself off.
It's all right.
Geographically off. That's right. I forgot you're.
It's good. It's all good.
And right, but the idea is to help you sort of with your practice tomorrow, right?
Yeah.
And that if you need to do a 2-year comprehensive evidence review, that creates a different type of document.
Gotcha. And do you have any other ones planned after the dietary?
We are in the active plan. We're in the active planning stages. The one that will follow that will be about conservative management of patients with advanced chronic kidney disease.
You guys are hitting all the high points.
And then the one that is like really in its infancy is going to be around CKM, cardiac kidney disease management, and really thinking about what the role the nephrologist should play in that process.
Nice, excellent.
So
this has been awesome.
So thank you so much for having me.
Thank you for joining us on Nephrology Times and talking to us, and good luck with your lecture.
Thank you so much.
Take care.
Great.